Good afternoon, and thank you for joining us today for this Youth SBIRT training. I'm Elaine Densley, and I serve as the Administrative and Program Manager for the Virginia Tech Richmond Center. We are delighted to be providing the virtual conference management and technical support for this training. At this time, I'd like to cover a few housekeeping items. This is a Zoom meeting, so we encourage you to leave your camera on, but be sure to remain muted unless invited to ask a question. We do invite you to interact with fellow participants and the instructor utilizing the chat. If you should have technical issues during this session, please message me or my colleague. You'll find us by looking for the comma VT after our name. It doesn't mean we're from Vermont. It means we work for Virginia Tech. Okay, so anyone with a comma VT after their name can help you with technical issues. All right, we have a very busy 3 hours ahead of us today, so feel free to get up and stretch as needed, but we have planned a 15-minute break for approximately 2:40 p.m. CEs are being given for this training, so please be sure to rename yourself to include your first and last name. This will allow us to track your attendance easier and ensure everyone receives the correct number of CEs. This can be done by right-clicking on your name on the screen and selecting rename. Everyone will also be required to complete an evaluation, which we'll drop it in the chat at the end of the session, and you'll also receive an email. So be sure that you fill that out as well. We are recording today's session, and that will be available on DBHDS's YouTube channel shortly. Thanks again for joining us today. And now I'd like to turn it over to Dr. Frizzidis.
Hello, good afternoon. Thanks for joining us, everyone. I'm very excited to be here with you today. So a little bit about me is in your information that you received. So I'm definitely not going to go over that. But what I do want to share is that I've been involved with supporting SBIRT implementation. So SBIRT screening, brief intervention, and referral to treatment for a number of years now, and in a number of different types of health settings, mental health settings, medical settings, integrated settings, school settings, and so on. And so very excited to be with you here today to specifically focus on SBIRT for youth. And typically the way that this gets defined is in that 12 to 21 or so year age group. So today we're going to spend a little bit of time helping orient you to that. My understanding and ask for creating this, of course, training was to make the assumption that some of you all and many of you all are working in fields where you've had some basic foundation and exposure to certain key concepts that really help support the delivery of a brief intervention, including basic communication skills and the like. So what we're really aiming to do today is give you the nuts and bolts of what SBIRT is, but really hone in on opportunities to practice the delivery of what we call the brief intervention. And we'll train you to one of those specific models. So I'm going to go ahead and get my screen share going. I believe, Elaine, if you are able to do so, drop in, and we'll be dropping into the chat at some point, or somehow making accessible to you all at some point, a PDF version of the slides, as well as some other resources that I'll be referencing throughout the training. So that will be available to you. If anybody wants that information in a hard copy format at a later time, just let us know. You can email us directly, email me directly, and we can get that information over to you that way as well. All right, without further ado, let me get my slides up here. All right, can I get a thumbs up? You all are seeing this introductory slide that says Virginia Youth SBIRT? Excellent, thank you. Okay, great. So what is Youth SBIRT? I'm just curious from folks, either you can drop something into the chat or just do a show of raising your hands really quickly via your participant feature. How many folks are already somewhat familiar with SBIRT? I'm seeing some are. And not, okay. All right, well, that's really helpful. This will help me sort of think through how to best address where we're all at for today. All right, thank you all. All right, so what is SBIRT? SBIRT was really designed as an upstream prevention approach. Is really designed to identify risk early on in a trajectory of risk and try to intervene early before problems get elevated and escalated to where they become more problematic. And so when SBIRT was originally developed, it was designed to sort of capture or quickly identify risk, quickly triage that risk, be able to provide a same day immediate intervention to those who are identified as at risk, but then also recognizing that you're going to have folks who are at higher levels of risk to become identified, who are going to need higher levels of care. So ensuring that you're able to identify and manage that as well. So this will make a little bit more sense to you as we go through the nuts and bolts. But I often hear about people asking about SBIRT and equating SBIRT with treatment. And that's not exactly the way I would compare it at all. It really is designed to be sort of pre-treatment level of intervention, if you will. Okay, so today we'll spend a little bit of time talking about what SBIRT is, what are the core components of the framework. It's a highly flexible and adaptable framework. So the great news is that I've seen this work in many different ways in many different settings. So I'm hoping that you'll all leave here today with a better understanding of how you could implement this as well. Best practices for effective screening, how to deliver and feel comfortable with delivering a brief intervention, and then understanding what the referral to treatment process within the SBIRT framework looks like. So why? Why the focus on youth SBIRT? Believe it or not, much of the SBIRT work started in adults 18 and up. And when you think about a public health approach or a population-based strategy where you're trying to identify risk early on, it naturally makes sense to start earlier on when people are starting to use substances for the first time. And we know that for a lot of individuals, that time is during adolescence. So that's why there's been an increased focus on testing and evaluating SBIRT in an adolescent population to determine its effectiveness for changing that trajectory of use during a high-risk time period for a lot of youth. And we also know that youth is very much, and substance use disorders in particular, are very much pediatric onset, meaning when you look at adults with substance use disorder, 9 out of 10 started using before the age of 18 and usually significantly before the age of 18. So if you're really thinking a little bit more upstream, how do we capture this and change that tide earlier on? The idea is we need to start earlier on and identify and have these interventions with youth early on. So we also know that adolescence is a critical period of time for substance use initiation, and that many youth are going to start using some type of substance. And for youth, it still tends to be nicotine, alcohol, and cannabis-based products that they're utilizing before graduating high school. And while some substances have been, through prevention and treatment efforts, been leveling off, and we've been seeing a really great sort of decrease over time, a few of those, and most recently marijuana and hallucinogen use, have been found to be on the rise, and nicotine use, of course, highly variable after a steady use of decline of tobacco use for many, many, many years. But we also know that risk changes over the course of that 12 to 21 or so year period, where as youth get a little bit older, the rates incrementally grow. So you can see that here. So you can see how the use rates of past month marijuana and alcohol use in ages 12 to 13, how that grows by 14 to 15, and then how that grows even further quite significantly by the ages of 16 to 17. So in thinking about ideal times to target, in some ways you might say the earlier the better. At the same time, it's clear that this isn't a one and done. And SBIRT's never designed to be a one and done. The idea is, and best practices are, having opportunities to identify risk for youth at least on an annual basis, if at all possible. All right. What else do we understand about why we need to be focusing on this? We know that adolescents who are engaging in some substance use, even if they're not quite at the level of substance use disorder, but then when they get to the level of substance use disorder, are still often largely undiagnosed. They have complex histories, many other sort of co-occurring and other experiences. And SBIRT is sometimes the way that we start to identify some of those risks when those risks may not be known to the provider. What does this look like for youth post-COVID? The National Council for Mental Wellbeing did a survey of youth in preparation for their Getting Candid guide, which is something that you'll see referenced as a resource in the PDF that Elaine put into the chat, which gives great information on how to frame the conversation, have conversations with youth around substance use prevention and what especially resonates with them. And we'll talk a little bit about how to build that into your brief interventions a little bit later on. But in doing this, they kind of got an assessment of youth and got a sense of how many youth are actually having someone speak to them about substance use since the pandemic began. And it was a pretty low number, 41%, whereas only 20% had conversations 1 to 2 times. Why is this relevant? Because in substance use prevention, we know that having frequent and regular conversations with youth around substance use prevention is actually far more effective as a strategy than waiting to have this one big conversation with youth at some point in their development, whether that be in a course, in a school, whether that be by a parent, by a provider, or so on and so forth. And interestingly, when you ask youth about who they seek out or would trust for information around substance use, you can see some of the examples there. And providers, community behavioral health providers, school counselors, therapists are all listed amongst those that they identify as trusted sources of information about substance use. At the same time, providers of all type had challenges during this, specifically during the pandemic, to engaging youth in conversations due to other sort of constraints. So one of the things that we want you all to start thinking about today is how can we more effectively help our youth with the support of the framework and the tools that the framework offers. And so one of the things we often start to think about, and I encourage you all to be thinking about, is when in your communities that you serve, what are the prevalence rates for youth and young adults, 12 to 21, for mental health and substance use risk? And how does that align with what you're seeing in your work? So for instance, I can say that in some of the areas of the state where we have supported youth SBIRT's early delivery, we have found that the prevalence rates that you see in national samples and even the youth behavior surveys are quite a bit higher than what youth are endorsing. So there's still a little bit of a discomfort for youth to sort of endorse risk in certain settings. And what we're hoping will happen is that over time, as more and more people are having these conversations and asking questions of youth about their substance use engagement, that those youth are going to warm up and feel more comfortable engaging in those conversations. But it's helpful to have a general understanding of what that actually looks like. Many youth, in fact, not just youth, but also caregivers, providers, all folks, we tend to overestimate the true rates. And youth are largely shaped by what they think others are doing. And when you think that most other kids are drinking alcohol, most other kids are smoking, and it's a very normal thing to do, and they're hearing from caregivers, perhaps, and other community members and media that, yes, this is the case. Most parents are allowing their kids a safe place to drink. Most parents are doing this. It's okay for youth to normalize, to try things out and to experiment. Sort of these notions actually overestimate the fact that while, yes, we do see rates of use that might be 10 to 20%, in some areas even higher, and for some age groups even higher, the majority of the youth are actually making choices not to engage in substances. And so having an understanding of what the true prevalence rates are will become relevant later on in your conversations with youth and the delivery of a brief intervention. The other thing is to be thinking about what's working well. So I'm guessing many of you all are here because you have an opportunity to speak with youth about substance use in particular. And the questions I'm curious about is, and I'd love to hear from you all about this. Maybe we'll use a chat because we are a large group here today, to start plugging in when you think about your conversations with youth around substance use and substance use prevention in particular. What works well? And then we'll get to what's not working so well in a little bit, but let's just start with plugging in some of what goes well in your conversations with youth, or what helps facilitate those. Thank you, Shelby. Being open and non-judgmental. You see me looking back and forth. I've had to have my slides on one screen and my chat on another. Honest in conversation. Yes. Being empathic and honest. Normalizing why the abuse may have started. Some therapeutic approaches, play therapy, role modeling, building rapport. Absolutely. You know, and I probably should have done this a little bit earlier. I'll do it here in a minute after a few other people chime in. Talking about peer pressure, right? And in particular, Robin, having probably people think through how they would respond in those situations. Trying to understand, not necessarily being understood. Okay, listening to their concerns. Absolutely. Great. This is all very helpful. So what are some of the sticky points? When you think about what are the times where maybe you have felt a little less effective in having your conversations with youth around substance use prevention, or things that you would hope to really gain or take away out of our conversation today, does something in particular come to mind? Going too fast in the beginning. Okay, so that's not working as well. Trying to discuss their peers. I don't know if that was lingering from the previous question or this one. But peer and peer influence is definitely important, and it can facilitate things going well, but can also be challenges as well whenever there's a peer group that's pulling one way. Staying in the here and now. Got it. Anything else? Okay, this is really helpful. So the goals for Youth SBIRT really are, oh, I see a few more coming in. Advocacy programs, everything is hurry up and wait due to red tape and waiting lists. Okay, thank you, Megan. Welcome. Right. So Dolores, I like that idea, trying to introduce alternatives that might be a little bit healthier when somebody finds that they're using something to manage a particular symptom or problem that seems to be working for them, at least there in the short term. All right. So the goals for Youth SBIRT are really, the training in particular, are really to help support folks in engaging with youth about substance use. And providers here could be any person that really interfaces with youth, whether it be a mental health setting, whether it be a community setting, and so on and so forth. But the reality is that you may only have a limited amount of time to connect with youth in your respective locations or your respective roles. Some of you may have more time because you have the luxury of a therapy hour. And we'll talk about where SBIRT sort of shines within a community mental health setting. And the good news about the SBIRT framework is that it is highly flexible, adaptable to a number of different settings, a number of different roles within those settings, and can help you have effective conversations in a fairly brief amount of time. So on that note, if folks could, I'm curious to get sort of a sense of the type of setting that you work in and your specific role in that setting. So for instance, are you in a CSB, another community-based mental health clinic, a medical practice? You know, what type of clinic environment or setting are you, a school are you working in? And then are you in that, okay, I see school social worker, your specific role. So that's really helpful. This is really helpful as we think through how to put the component parts into practice and how I orient you to that. Okay, great. I'm going to give a few folks a few more seconds, maybe 20 more seconds to to continue to chime in. All right, excellent. So a variety of different settings, which is actually really exciting. Okay, great. So now seriously, what is Youth SBIRT? And as I start to go through these various component parts of what Youth SBIRT is, try to be thinking about how this might look where you work. All right, so SBIRT can be implemented system-wide within a particular clinic, and component parts of it or setting and component parts could also be implemented by a specific provider, depending upon if that's what fits for that particular setting. So that'll make more sense as we go through it, but be thinking critically about how this could look within your specific settings, because if there's any uncertainty by the end of this, we want to make sure that that is clear for you. So I hope that you'll ask questions if there is any uncertainty on that. So SBIRT has 3 core component parts, and they map on to the acronym. The first is screening. The notion here is universal screening. So if you're a school social worker, maybe that might look like all 7th graders in health class, or all 8th graders in homeroom class, or whatever you determine that population is. In a clinic, it might be all people who come into the CSB for an intake appointment, for example. The idea is there's no look test, and I know I'm preaching to the choir here, for who might be at risk. Now, in certain settings, the risk becomes known to us. People are either self-referred or other referred to you for specific substance use services or risk or potential concern. And that's okay. But the idea with SBIRT is, if we really want to get upstream and lower risk before it elevates even further, then we start earlier on. And the only way to do that is through universal screening. Then, so that's the S, screening. BI in SBIRT stands for brief intervention. Brief interventions are designed to be immediate, short, anywhere from 5 to 10 minutes typically. And therefore, any individual who's identified as having been at risk for substance use. Usually that is because there has been some engagement in substance use during the period that you are assessing. So that is a brief intervention. Brief interventions are not treatment. Brief interventions can be offered as, and they often delivered as a way of providing sort of a same-day change-based opportunity and conversation with an individual to see if they might be willing to make some type of change to their use. And then for those who might be at a slightly higher level of risk, you get to that referral to treatment piece. So you might deliver a brief intervention and determine, you know what, this individual's at a pretty regular level of use where treatment is going to be clinically indicated, or they're already coming into you as a treatment referral. And what you'll follow your typical sort of treatment process. Say in the school, it may be referring out to the community or to somebody within the school system for ongoing treatment and follow-ups, if that's determined that's clinically indicated. And the good news is by using validated screening tools, which you'll be introduced to, all those screening tools give you clinical guidance based on the scoring of the tool as to what level of intervention is indicated. Is it brief intervention? Is it going to be a referral to treatment? It'll give you that sort of guidance and indication, so you get that a little bit later. So how does this look? I used a couple of examples of some commonly used tools. I'm curious, I'm guessing a number of people are probably familiar with the CRAFT, the C-R-A-F-F-T. There are several versions of the CRAFT. It is one tool that gets often used. It's not the only one. We'll talk about others that gets used, but it is an example of one tool that looks at 2 sort of levels of risk. It looks at, one, has the youth used any substances in the past year? And that's considered the initial screen. You'll see the PHQ-2 there. That's a depression screen. Oftentimes when we're screening for substance risk, we're also screening for other co-occurring as well. Depression at a minimum, anxiety ideally, maybe trauma as well. This, again, these are clinic by clinic decisions or provider decisions, depending upon how you're doing this. But if we focus on the idea of what is screening, so screening can be broken down into two parts. There's the initial screening, and then there's the secondary screening. In both of these, what you try to do is you say, okay, well, if I'm going to be universally screening, say, every client that comes through the door or all of the 8th graders in our school, the majority of youth aren't going to necessarily need the full screen because they're not going to be utilizing substances. So what you do is you start with that initial screen, which basically tends to get at a few sort of triage questions. And then if they score positive on those, it naturally opens up or unfolds to the next. They would actually complete the next remaining items. That's how sometimes people will do it, depending upon their methodology. Other times people will just give the whole tool, and the tools often not offer guidance. If it's self-administered and the youth is taking it themselves, it says, oh, if you answered no to these questions, just stop, right? Something like that. But that's the idea between the initial screen and the secondary screen. Depending upon their total score, someone is going to fall into one of, there's 3 shown here, and I apologize, it really should be 4 categories. What you don't see here is no risk. No risk is not shown here, only low, moderate, and severe. No risk is an opportunity to give positive feedback and reinforcement and praise for those choices that an individual is making. Low risk is when you're looking at a brief intervention is what's clinically indicated. That's what the BI is. Now you'll notice 2 levels above that, moderate and severe risk. In both moderate and severe risk, this is where you're looking at chances are this individual is highly likely to potentially have a substance use disorder and would benefit from further assessment and or treatment for that substance use. The reason moderate and severe are split out is in the SBIRT framework recognizes, and it kind of looks at levels of care, that moderate risk tends to be appropriate. Oftentimes you're considering outpatient level of care, whereas for more severe risk, you might be looking at more higher level of care than that, or specialty substance use care. So a substance use disorder specific program or an IOP, whereas moderate might be, they're using some substances. There's clearly, oftentimes there's co-occurring concerns as well in that range. And they would benefit from some level of outpatient treatment that addresses the substance risk and other sort of co-occurring as well. But they would probably be fine with just that outpatient level of care and not need a higher. Again, this is a screen. A screen cannot triage and determine level of care from sort of like an ASAM perspective at all. But this is for those who are doing screening who may not be in a treatment setting. This is that giving them an idea of, if I'm going to send a referral out, say you're a school, who am I going to send that referral to reduce the number of touch points that youth needs to make in order to get to the place where they need to be seen most appropriately and be eligible for those particular services, right? So this offers that sort of level of guidance. Okay. We'll pause for questions in just a minute, but you can start putting them into the chat if you have them. When you look at sort of SBIRT projects that have been done that focus on youth, and you look to see sort of in general, how are youth screening? You'll notice that in general, if you're looking at past year use, about 80%. Now, again, this is the general population. This is not necessarily, this would look different. This pyramid will look different across different settings. So it might look different in a criminal justice setting than a school setting than it would a community treatment setting. But general population, the majority of youth are not going to be engaging in risky substance use. And for those who are, the vast majority of those who are fall in what's that low risk range. And really, this is that sweet spot of SBIRT. So we've had treatment available for those in the moderate and severe range for a long time. What we've not had as available is a response for that 15% that might fall in the lower mild range, where some level of a conversation or a brief intervention can be delivered when perhaps it may not be clinically indicated that youth may not be at a level where they really need outpatient treatment. So what's the care level, the next level down that would be most appropriate for them? And that's where the brief intervention came to be able to fill in that gap there and really address that particular risk category, if you will. Now, that said, it still does something to, I think, add and accentuate opportunities for those youth who are following into those higher level categories in terms of facilitating their acceptance for referrals and acceptance and willingness to engage into treatment. All right, I'm going to pause right there. I'm curious what questions are coming up for you as we've talked a little bit about what this framework looks like and what it is. I'll just quickly mention this while you're getting your questions down. This slide shows some responses from youth who participated in Youth SBIRT and were followed up 6 months later and were offered an opportunity to give qualitative feedback on what their experiences were and what worked for them or what they liked or didn't like. And, you can see this here, that in general, folks felt open to having these conversations, at least those who participated in this. And you can see some of the specific, feedback that they give in terms of just enjoying that they felt they had someone that they could be honest with and talk to, and it was very much conversational. They didn't feel like they were being judged or anything like that. All right, so before we pop onto screening, let's take some questions. Or you can use your raise hand feature if you know how to use that via your Zoom controls, and then we'll see that and we'll be able to ask you to unmute. All right, I'm going to keep moving forward. I haven't seen any come in yet, but feel free to continue to plug them in as they come in. And Lisa or Elaine will kindly redirect me to your questions if we need to stop if some come in and I don't observe them. All right, so screening. Now, for some of you all, based on the settings you indicated, it could be that your purview is just going to be screening at your setting. It could be for some that because you're in a setting that's already doing full assessment, screening is maybe a helpful piece of that assessment at an earlier stage. So I know there's a number of CSB folks on the line, and talking with CSB colleagues and other mental health, community-based mental health agencies who deliver this, oftentimes screening is done at the time of intake before somebody comes in for an initial appointment where they might be more fully assessed. And this is a way of being responsive to an identified need, offering some level of intervention at that time, hopefully facilitating that ongoing motivation and commitment to come back for that next subsequent appointment, which is going to be a little bit more elaborate, in which case you'd probably go through more of the assessment and or start initiating treatment at that time. So think about the different ways screening might make sense within your unique settings. We're just going to talk about two. Like I said, there are not more, there are more. The only recommendation within the SBIRT framework, or requirement rather, is that you use a validated screening tool. So in other words, getting away from this loosey-goosey, you don't use substances, do you? Are you using any tobacco products? Are you doing any drugs? Things like that. The reason being is oftentimes they can be worded in ways that discourage use or stigmatize it. It could also be not always comprehensive. And so the idea is to try to use validated screening tools for a couple of reasons. It addresses those concerns, but then it also helps us best understand risk level, which informs intervention needs. So we're going to talk about something called a screening to brief intervention, which is fairly new, and the craft. I've got the 2.1N here because that's one of the more recent versions, and you may be familiar with some of the previous ones. Okay, so the screening to brief intervention, this came out in about 2014 out of Boston Children's Hospital, and it asks specifically about past year use across a couple of different substances. Their research highlighted that youth are most likely to utilize tobacco, alcohol, and marijuana. So they had those as their core substances, and then stop if those were never, nobody continues. But if somebody had used any tobacco, alcohol, or marijuana, then they were to answer questions about their use of prescription drugs, illegal drugs, inhalants, and they have herbs or synthetic drugs here. Those were the categories that they sort of sectioned out. I've heard people say that, you know what, in our population, we see a good amount of youth coming in utilizing prescription drugs. And so one of the things that we've encouraged folks to do is think through, okay, well, you're not restricted to delivering it just this way. You could just have everybody complete all of them if you wanted on that first page. And if that's what makes more sense for your particular audience. But I just like to make that caveat because people will often ask, well, why those 3 drugs at the top or substances? And that is just their research showed that you are much less likely to use the bottom sets of substances if you weren't also using either tobacco or alcohol or marijuana. I have a quick question from Sandy. If you can see that this one makes sense to use the assessments before they go to the juvenile system. Yeah, absolutely. Yes, you can. So great question. So, but just to come back to Sandy's question, absolutely. Ideally, yes, you would capture early on, but at the same time, it may not be caught early on. So later in the system, it still makes sense to do screening, even as they're entering into the system as well. For tobacco, that is one of the things that people sometimes dislike about this particular tool is that it still says tobacco as opposed to nicotine-based products. But you could certainly indicate tobacco or nicotine. So the youth very quickly or easily, or you, if you're asking this question, can just check off what the relative frequency is about how often they're using these substances. And the S2BI gives guidance based on if they're, when you think about the various substances that they're using, if there's no use, you get positive reinforcement. If they're using once or twice, you can ask follow-up questions like those substances we talked about, and then they would all get some level of brief advice. If it's monthly use, you're looking at a motivational intervention. Weekly use, again, same idea, same motivational intervention, and at this point, you're looking for a strong referral to treatment. So you can see here how, depending upon how a youth scores, that influences sort of the overall level of intervention that you would want to deliver. And the same is true for all of the validated tools. So you'll see that as well when we go to the craft next. Whoops. Oh, I'm going to come back to that slide. But here's an example of the craft 2.1N. So the craft 2.1 plus N includes a specific item number 4 that wasn't on previous versions of the craft. So the craft asks about past year use of alcohol, marijuana products, any other type of substance to get high. This could be licit or illicit. And then they've added in using nicotine or tobacco products. And the way that the craft works is that every person who's administered the craft would get these 4 questions plus one question that asks about their whether they have ridden in a car in the past year by somebody under the influence. So it's this first question here. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? If for some youth, the questions are just going to stop right there. So if they've not used any substances in the past year, they'll only be asked this car question and then they'll be done. For anybody who's used any substances in the past year, they'll also get these remaining questions about the potential impact. They give you a sense of the severity of their substance use. So are they using it to relax, feel better? Are they using it alone? Have they had memory lapses as a result of the substance use? Are others that are close to them telling them they need to cut down, expressing concern? And are they getting into any trouble? So there are many versions of the craft available. And again, this is a publicly available tool for you all to be using. It can be used as interview, administered or self-report administered. Both tools can. And the craft gives you a few sort of scoring ways of scoring this. So basically, the craft has 10 different items. The first 4 items are asking about whether they've used any substances, and then it has 6 items that ask about problems affiliated with that substance use. Those are the CRAFFT items. So somebody would get a total score based on how many CRAFFT items that they scored or endorsed as positive as yes. So their score could technically go up to 6 because there are 6 of those items. So the way that the craft gives guidance is that if anyone scores 2 or above, that's high risk. This is where you're looking at delivering a brief intervention as well as referral to treatment. Okay. Now, then there's those who are under that 2. So somebody who would be at medium risk would be somebody who has ridden in a car with somebody under the influence in the past year, or has not, but did report some level of substance use in the past year. And then the low risk here is really kind of no risk, but it's somebody who's not done any of this. They report all no's, and it's an opportunity to give encouragement and positive feedback for the healthy choices that they're making. In youth in particular, there's that piece is built up more so than it is for adults of how do you give that low risk praise to say that, you may or may not have been exposed to some of this, and it sounds like you're making healthy choices. I'm curious what's led you to make some of the choices that you have made where you've not used substances, and sort of reinforcing that, and have you thought about how you might respond in a situation in which you were offered a substance to use and how you would handle that, so it gives an opportunity to help them sort of think through that as well. Okay. Before we go on to the brief intervention piece, I'm going to pause right there to see what questions you all have further about the screening tools. I went over them pretty quickly. You have copies of them in the PDF that was dropped into the chat earlier. Any questions at this time? All right. So what is a brief intervention? A brief intervention is really just designed to be a conversation that you have with a youth that is aimed at helping bring some awareness to their behavior. In this case, the behavior we're going to be talking about is substance use, and helping them think through their reasons for and not for using that substance, and seeing whether or not we're able to build some motivation to activate them towards either continuing to make healthy choices or starting to make healthy choices. So there's a few goals. There is a goal of sort of educating or informing. Here again, patient, client, we're using them interchangeably. I do this training in many different settings. So this is sort of, again, think about the language that works best for you. Is educating the youth on safe levels of substance use, increasing awareness of the consequences of substance use, motivating towards change, and assisting them in that plan, in that process for them. Now, you'll notice for those of you who work with folks further along the continuum of substance use risk, that this 5 to 10 minute conversation isn't gonna do the trick, or isn't gonna cut it, to achieve these goals. That's why they're coming to treatment. They need that higher level of care. But again, think about that sweet spot of SBIRT. SBIRT's really trying to get that early emerging risk. So for those youth, oftentimes these conversations can be really helpful, especially in planting seeds. And that's a lot of what we do with this type of a brief intervention, which is based in motivational interviewing, is really trying to sort of open that door up for consideration and contemplation, and allowing them, guiding them to the choices they're going to make. Okay. So we are shifting into conversations with youth from the screening, and I also say, and parents or caregivers in this case, it's important to just keep a couple things in mind. And you'll notice that many of you come from behavioral health backgrounds. So this is all going to make great sense. That is very sort of collaborative, very motivational, very reflective of their unique values, desires for change, an opportunity to increase understanding of health concerns as well as strengths, making sure matching plan with readiness and needs, addressing other co-occurring concerns or risks, and being sure to engage caregivers in that process when it makes sense to, which is typically when you're getting to that higher level and you're looking to be involved in helping get a youth connected to treatment services. So what I'm going to do is I'm going to show you actually a demonstration video really quickly of what an SBIRT brief intervention looks like. And then what we're going to do is kind of break it apart and come back and talk a little bit about some of the core MI tools and strategies that you will have observed in that video and how it all came together. Okay, so let me go ahead and stop the share here. And you'll know there are only so many videos out there for that I would feel comfortable demonstrating as pretty well delivered brief interventions. And both of them are in medical settings. One's a pediatric primary care, one's in a hospital-based setting. But truly, these conversations can be had anywhere. All right. So let's start with the shorter one of the two. Just a moment to get this screen share activated for you. All right. Is everyone able to see the little Jacob on the screen? All right. You know what? I don't think I activated
Jacob
my
is a
audio.
14-year-old boy presenting for a sports physical exam. He completed.
Are you all hearing that? Can I get a thumbs up? You are? Okay. We'll just keep going then.
Completed the craft screening tool and answered yes to the relax question. The physician has completed the physical exam.
So Jacob, everything looks very normal on your physical exam. Do you have any questions for me?
No.
I see that you filled out our alcohol and drug questionnaire. Is it okay if we go through this together?
Sure.
What we talk about is confidential.
Jacob is a 14-year-old boy.
Apologies. Apparently, I stopped the screen share. Share sound. Okay. We'll try this again. Thank you for letting me know. As I get this started, please give me a thumbs up.
Presenting for a sports physical exam. He completed the craft screening tool and answered yes to the relax question. The physician has completed the physical exam.
So Jacob, everything looks very normal on your physical exam. Do you have any questions for me?
No.
Okay. I see that you filled out our alcohol and drug questionnaire. Is it okay if we go through this together?
Sure.
Okay. What we talk about is confidential. I only tell your parents about what we say if you give your permission or if I become worried about a danger to you or to someone else. Does that make sense?
Yeah.
So let's take a look. So I see that you have marked that you sometimes use alcohol and that you have used alcohol to relax, feel better about yourself, or fit in. Do you mind telling me a little bit more about your alcohol use?
It's not a big deal. Sometimes with my friends, we'll drink a few beers and when we're hanging out or when we're at a party. And sometimes rum and cokes.
Okay, so how many do you usually have at a time?
3 or 4 probably. I don't keep track.
Okay. And how often?
Probably about once or twice a month.
Okay. So you drink with friends, sort of 3 or 4 beers or mixed drinks 1 or 2 times a month. How long have you been doing that?
Probably since last October.
So for about 6 months. I'm curious, what do you like about drinking alcohol?
What do I like about it?
Yeah.
I don't know. It's just fun to drink with my friends. Like when we're at a party at someone else's house and we're drinking with other people that we don't know. It tastes good.
Okay. So it sounds like you feel relaxed and have fun when you're drinking with friends and you like the taste.
Mm-hmm.
Okay. I'm also curious, are there any parts about your alcohol use that you don't like?
I don't like when I get sick in the mornings because of hangovers and when I start throwing up, and I don't like that.
Have you ever experienced a blackout, like when you've been drinking and you wake up and you don't remember what happened?
No, but that happened to someone I know though.
And have you had any problems related to your drinking alcohol, like at home or school or somewhere else?
One time I missed first period at school because I had a hangover and I was late getting up. And Mom got mad at me because I wouldn't get out of bed, and she said she knew I had a hangover.
Have you told your mother that you drink with your friends?
No, but I got grounded for 2 weeks after that.
So more negative things about your drinking, like getting into trouble with your mom and missing a class at school when you had a hangover?
Yeah, but I only missed school once.
Okay. I see on the questionnaire that you have not ridden in a car with someone who's been drinking, and you haven't driven a car after you've been drinking. Is that correct?
Yeah.
That's great, and I hope you continue to avoid those things. As your doctor, I want you to know that I'm concerned about your drinking. When teens drink, things can go wrong, like injuring yourself. Even when you don't drink to excess, though, your brain is still developing and is very sensitive to the effects of alcohol.
Okay.
That's why I recommend that all my adolescent patients not drink at all. So if you were to think today about how ready you feel to stop drinking alcohol on a scale of 0 to 10, with 0 not being ready at all and 10 feeling very ready, what number would you pick?
Probably a 5.
A 5. So I'm curious, why didn't you pick a lower number like a 2 or a 3 that would mean you're only a little bit ready to stop drinking?
Well, I guess I'm just tired of getting in trouble.
Okay. What could you do to avoid getting into trouble?
Not drink?
Have you ever tried not drinking or stopping drinking?
No, not really.
What some people your age do is try stopping drinking for a period of time just to see what that feels like.
I could probably do that.
So how long do you think you could go without drinking?
I don't know.
Do you think you could go 2 months without drinking?
Yeah, probably.
What things would make it easier for you to not drink?
I could probably drink something else when my friends start drinking, like just Coke.
Anything else to make things easier for you?
I could probably hang out with some of my friends who don't drink. We're inviting them to parties and having fun, because not everyone drinks at parties.
Okay. Is there anybody in your life that you can talk to about this who'll give you some support for not drinking?
Yeah, my friends who don't drink would probably be happy that I'm not drinking either, and they'd support me.
Great. So you've come up with some reasons to stop drinking, like having hangovers and throwing up and getting into trouble. And you've developed some strategies to try to not drink, like spending more time with friends who don't drink or having non-alcoholic drinks when people around you are drinking alcohol. I think that's a great plan. I'm really proud of you for giving this a try. How about if I have you make an appointment for 2 months from now, and then I'll see you back and we can see how things are going.
Okay.
All right, let me get this turned off or it will start over again. Okay, great. So let's talk a little bit about that video. I'm not going to screen share again just yet because we don't need it just yet. First, let's talk about the video. What are some of the things that you liked or you thought went really well in that brief 6 minute, 46-second or something like that conversation that was had with the youth around their substance use? You can plug into the chat, you can unmute yourself and chime in. What are the things that worked well or that you liked about that? Okay, so Hashi shared why he was drinking and what he could do to change things. Yes, she definitely gave him space to be open, engage in what he's willing to do, helped him think through alternatives, offered ideas, expressed his concern. Yeah, she wasn't judgmental. The scaling question, yeah, not challenging him. Yes. So, you know, a lot of these that you all are highlighting are very intentional and they're consistent with the model of the brief intervention that you'll learn today. something called the brief negotiated interview. And it really hones in on a lot of the core MI principles that you all are commenting on here, as well as the components of, using a ruler or scaling to help build that readiness, eliciting a decisional balance or pros cons way of thinking about the substance, really working as a guide to help them sort of through and thinking through their process and their approach. Absolutely. Are there things that maybe as you reviewed that video, and again, these are, scripted videos of sorts, but are there things that didn't sit as well or they had questions about? And again, keeping in mind that this was a pediatric primary care setting with a medical provider. So how somebody would deliver it in a school or in a community mental health setting would look very different. The core components of the intervention would be there, but perhaps some of the information that you would share might look a little bit different. Anything that didn't go as well, that you didn't like? Identifying alternatives. Sherry, if you're comfortable coming off on mute to explain that a little bit more, I'd love to learn a little bit more about what you're.
Yeah, no problem. So in the past, so in the video, he created some really great solutions for what he could do differently. But, for some of the youth that I've worked with previously, that hasn't necessarily always been the case. It's, I don't know, I'm not sure. My friends are my friends. They know what I do. Sometimes they're involved in helping encourage the behavior. So some of those solution focused, like what should happen next, don't always, for me, necessarily happen as smoothly or as cleanly as maybe what was shown in the video.
Yeah, so maybe sometimes you have to work a little bit more intentionally as the provider to elicit that information or offer ideas, especially when you hit up like, if there's an environment or context in which that is so much the norm and the expectation for behavior, it can make it even more difficult. Yeah, he's saying yes, exactly, for those individuals to even consider an alternative because in their mind, there is no other alternative. Yes. There was a piece about a couple now coming in about parents and confidentiality. So let's talk about that. So with parents and confidentiality in general, we'll start at confidentiality. Is in general, substance, well, let me take it a step further back and say that when you're thinking about implementing SBIRT, it's important to think through how your specific agencies think through confidentiality and when it is appropriate to break confidentiality. So in general practice, youth disclosing substance use is not typically something that unto itself would lead to a break of confidentiality unless they were engaging in high risk substance use. That could be based on the type of substance they're using, the method of administration of the substance, for instance, but just the use unto itself wouldn't necessarily for many settings. Now, I worked with settings that have a very low bar that have said, well, you know what, any use is really dangerous for youth. And they wanted to say that any use would mean we're going to let your parents know or caregivers know if you report any use. The drawback to that, while it's a very conservative response and approach, is if you're, and you should be forthcoming with youth before you're screening or at the time of screening about what is protected and what is not. It really does limit opportunities to intervene with youth when the bar for confidentiality is set really conservatively. But what I found in outside of, in most settings where there is a behavioral health or medical or similar substance use counselor type provider providing a service, that bar isn't typically set that conservatively. But you do need to think about what it is that fits within your respective agencies. SBIRT doesn't give you guidance on that. It's a framework. You have to use your own, refer to your own policies. But as long as you are appropriately communicating that to the youth and they understand, then they're not going to be as alarmed when it comes time to say, hey, we really should engage your parents or your caregivers. The way that pediatric, in this case, primary care works with this, and we typically train providers to deliver the brief interventions, is typically a youth will do a medical exam, often with a parent or caregiver in the room. They do the medical exam, then the caregiver leaves. Then this is where they talk about the behavioral health concerns, the substance risk, mental health that might be endorsed, other things that maybe the youth wants to talk about in absence of the parent, maybe reproductive information. And then the goal is the parent comes back in, or caregiver at the very end. And this is similar to treatment, how you may start a session with a youth or with the family, and then you work with the youth, and then you may bring the family back in at some point, if not that session, a future session, to check in. And you have a negotiated conversation around, what do you feel comfortable sharing with your caregiver? What would you feel comfortable with me sharing with your caregiver? And then you sort of make a determination that way about how you want to handle that. So again, there's different ways to do that. And I hope I appropriately addressed those questions. I'm going to come back because there were a few others that came up. Okay, Nicole, you said yes, that was good. Okay, that was responded to. Oh, Robin, setting up a 2-month goal. Yeah, that might work in that setting, but typically if you have an opportunity to contact a youth more frequently, you would certainly do that and do a follow-up. Brief interventions can be multiple. This gets to Sandy's question, which I'll get around to. Brief interventions can be multiple. They don't have to be one and done. And it's very typical to kind of check back in for youth to see how they're doing, if they're making their plan, if they encounter any issues, and they do some troubleshooting, just to keep them on track. And similarly, for those who get referred, having multiple checkpoints to continue to follow up with them to keep that motivation going until they're able to get connected to a provider. It's interesting, Patrick, about are they that honest? What we have noticed in Virginia so far, as we've been implementing Virginia Youth SBIRT in pediatric primary care in particular, is that we're seeing about a 10 or so % endorsement rate of substance use, which is pretty typical for SBIRT in primary care and school-based settings across a number of different states, but it is under what you see on youth risk behavior surveys. So not everybody is, but what we find, and I think this happens with adults too, is over time, as you normalize that conversation and they know they're going to be routinely screened and that it is going to be, unless it's an area of concern or significant risk, confidential with the provider, that we have seen them engaging, but not everybody. Okay, so Sandy had asked a question previously about this approach and how it fits with some of the risks that they're seeing. And specifically the question was, well, just to summarize it, so SBIRT again, and Sandy, you caught on to this, SBIRT is an upstream approach. It really is designed for upstream. It has some mechanisms in place to try to help support those individuals who are identified, who are at higher levels of risk, but it is not itself a strategy to support overdose prevention or to deliver treatment. That's just not what it is. There are those strategies out there, they do exist, and this is kind of its lane, if you will. But it naturally blends into a broader comprehensive plan that a community may have. So providers doing SBIRT in the community is great for upstream. You still need treatment, you still need overdose prevention. And Eleni, it looks like, offered some ideas that they've used in their community with overdose prevention, in particular, delivering Revive trainings, and as well as equipping families with Narcan. And there are strategies out there, not only for treatment, but then also for overdose prevention. Now there's a lot more focus on how can we do more harm reduction and overdose prevention, especially fentanyl poisoning prevention, through awareness, through drug information, through drug education. And because it's so new, for that particular substance in particular, there's not really a strong evidence. So we're sort of trying to leverage information from the literature on drug education and prevention to kind of apply to that. So, but yes, SBIRT definitely is more of that upstream approach. Now, what we have seen SBIRT be helpful is not so much in the brief intervention per se, but in, the SBIRT framework per se, but the brief intervention specifically, as I mentioned, can be delivered multiple times. So you can do multiple brief interventions. So we've seen this where you have someone who's high risk, you get them to a point where they're interested and open to engaging in services. And can you, at a minimum, continue to have frequent touch points with that individual until they get connected to care as a way of continuing to provide them some level of support, some level of ongoing motivational enhancement in, as they wait to get connected, which sometimes those waits can get lengthy. So that is certainly one thing that we are aiming to try to encourage folks to do when they have the capability to do that. The more frequent touch points, sometimes the better for those individuals. And let's see, it looks like Patrick, the setting is critical for screening and establishing initial scores. Legalization of marijuana, parents are getting high and justify that to their children, right? So we do know that, and caregivers can be educated in this process as well, where appropriate. We do know that for youth, whether we're talking about a legal substance or not, folks like to focus on the legalization with cannabis, not providers, users of the substances, like to focus on the legalization. But, with youth, when you think about the other substances that are of primary concern and that have been for a long time, they're legal substances. They're just not legal for that particular age group. And recognizing that the youth brain is still developing till 25, if youth can delay onset of any use until ideally 25, but at least 21 or later, their chances of having problems with substances later in life drop exponentially. They drop exponentially. And so the more that we can help encourage parents around clear expectations of what's okay for me and what is okay for you and your developing brain are two different things, which can be a little bit tricky or hairy, but it is important because we know that when parents have clear expectations around what is appropriate for a youth or not as it relates to substances, that can be a big protective and or risk factor. So some of that is how do you negotiate that when the parents may be modeling a behavior that they're encouraging the kid not to engage in. And so sometimes the middle ground there is having that conversation around why this is something that is okay for an adult, but for you at 16 would set you up for a lot of challenges, right? And so recognizing when you've trying to get them to understand that they're at a time of they're getting faster, they're getting, smarter, they're getting, their brain is just helping them do so many things so quickly. And it could really slow that process down and hinder it if they started using substances regularly early. But yes, good point, Patrick. That is a trickier one. All right. So what we're going to do now, we had talked a little bit about taking a break right around now. And since we're about to segue into another theme, I thought may as well just capitalize on that break time now. So let's go ahead. We had mentioned, I believe it was 15 minutes. Yeah. Okay. So it's 2:40, almost 2:40. So we'll plan to resume at 2:55. So give folks an opportunity to walk around, move a little bit, get some refreshments, and we'll see you back at 2:55. Welcome back, right at 2:55. So let's go ahead and get our screen share started. If you have any questions that have come up for you over the course of the last 15 minutes that we had our break, feel free to plug those into the chat and we'll go ahead and get to those here in a moment. All right, let's get this slide show going. Okay. Are you all seeing the large slide? Are you seeing the one with the little note page? The large screen, the large one?
We can see your presenter notes.
Okay. I don't know why I did that this time around. Let me change that around. How about this time around?
Perfect.
Excellent. Great. All right. So we've already mentioned this, but the brief intervention is based on principles of motivational interviewing. It is not motivational interviewing proper, in that motivational interviewing is a much larger thing, and an approach and an intervention, but the brief intervention does borrow from the general principles of motivational interviewing and many of the strategies that are utilized in motivational interviewing. And some of the key goals that MI provides that the brief intervention leverages is the fact that recognition that motivation needs to be ongoingly reinforced and monitored, that it can support, MI can support engagement and can support activation for behavior change. One of the things I think that's really kind of important to remember, and all things that we do regarding behavior change, is that just like us as adults who feel two ways about behavior change, youth do as well. So even though a youth may really understand what might be, the healthier option for them or what could be potentially problematic for them, they're also in this conflict at times between what they might want to do, but then what they also feel pulled to do. And so a lot of what we do with the brief intervention is based on that notion of how can we help understand the ambivalence that's going on for the youth in the context of the brief intervention and pull that out into the conversation around getting them thinking about how they would respond to that and what makes most sense for them at this particular time. So because the brief intervention is so short, you'll get great use out of using your basic MI communication skills. And these communication skills that get used heavily in the brief intervention, obviously active listening, and then using your ORs or open-ended questions, affirmations, reflections, and summaries. So we'll go through these pretty quickly because my understanding is that you all have a good amount of understanding of what these are. So when you're thinking about open-ended questions, it can seem tricky to do this when you have a short amount of time with individuals, but if you use open-ended questions, you're more likely to get more information in a brief amount of time. The individual you're speaking with is going to feel like you've listened to them more. They're going to feel more heard, understood, and they're also more likely to feel that you spent more time. There's actually been studies of this, more time conversating with them than in fact you may have. When you're then comparative to just using a lot more closed-ended questions. So the goal here is, though, to try to get exploratory information from the youth to help carry that conversation forward. So we'll do a quick exercise, give you all an opportunity to transform some of these closed-ended questions to an open-ended question. So instead of asking a youth, do you enjoy smoking marijuana? What might you ask? This wheel here gives some really great ideas for words that can be used to help kind of turn closed to open-ended questions. Can you describe how smoking marijuana makes you feel? How does it make you feel? Absolutely. Great. Yeah. What are the reasons? What do you like about it? Of course. Great. Do you have any concerns about how your drinking is affecting your health? How about we transform that one? What concerns do you have? How is drinking impacting you? Absolutely. Great. All right. Affirmations. You all nailed open-ended questions. On to affirmations, which are just an opportunity to provide a statement that acknowledges someone's experience, their struggle, their efforts, their expertise, their strengths. One of the things that we want to try to avoid doing too much is overpraising. Overpraising in the sense that we let people know that they walk away with a sense of, oh, this is good, this is good, this is what they want me to do. So then if I don't do this, then I'm somehow not achieving a certain bar or a certain judgment that they may have. Because then if this is what they define as good, then the alternative is not so good. So here's an example. So for instance, I think it's really great that you want to cut back on your drinking. A potential trap might be, okay, well, now what if I don't cut back on my drinking? Now, this one's a little bit tricky, right? Because you want to say, yeah, I think if this is something that's important to you, that makes a lot of great sense. And I'm here to help support you in that. But you don't want to over amplify that. I am so relieved and so glad that you're wanting to cut back on your drinking. It is absolutely the best thing for you. You know what I mean? You don't want to over amplify it. So even this, you can transform this to be an affirmation that is not high of praise or not overly praising, so that you don't fall into that trap. Other examples of affirmations could look like, oh, you've given this a lot of thought. I understand these urges have been super challenging for you. You're really hanging in there with them. Here's a quick example of Trudy. Gives you an opportunity to form an affirmation. So I'll give you a chance to review this quick example and then think about what might be a strength of Trudy's and how would you use that strength to build it into an affirmation. It's a big step to admit that your addiction is a problem. Okay. So, and what is the strength that you are highlighting with that? Okay. Well, it kind of, we got that next. Trudy is insightful. Yeah. And recognizing that this is potentially harmful. The self-awareness. Absolutely. So really highlighting the self-awareness. That's great. Any other examples on this one before we move forward? Yeah, she realized the habit has definitely transformed. So one of the best ways of thinking about, or sometimes the easiest ways of thinking about starting to generate affirmations, if you're not as used to, creating those and affirming people, is to do just that. Think about what are some of the strengths or, the challenges that you're observing and how might you sort of reflect that back via an affirmation. All right. And I used a word just now that we're going to talk about in more detail, which is reflection. So in motivational interviewing and also in the brief intervention, we really kind of differentiate between two types of reflections. Simple reflections, which really kind of reflect back content and or emotion that you're hearing, and then complex reflections that really go beyond what's been said, kind of what you're sensing under the surface. It's making maybe a little bit of a leap or a guess around something that you want to bring up. That you sense might be happening and offering that into the conversation. And reflections do go a long way in helping sort of validate a person's experience, making sure that they are being understood correctly and that you're hearing what they're saying. Okay. So for some examples here, here's a simple reflection example. Like youth might say, I hear what you're saying about my drinking, but I don't think it's such a big deal. So a provider might say, so at this moment, you're not too concerned about your drinking. These can go in a lot of different ways, but this is just kind of a simple reflection of what is specifically out there and on the table and it's been said. Here's one that might reflect meaning or feeling. Somebody might be feeling like a little frustrated. I try, but hardly ever succeed. Every time I try to quit, I start back up again. I just don't know what to do different. Provider, quitting smoking is important to you and you're feeling discouraged. I also hear that you're persistent. This change must be really important to you. So this is sort of multiple reflections back into one, which they're highlighting and acknowledging that frustration that they're feeling, that discouragement that they're feeling, but then also noting the strength that they do continue to come back and so they are persistent and this is something important to them. All right, so now we'll practice. Let's imagine you hear this statement out of a youth. I don't know if I can quit smoking. What would my friends think? What might be a reflection back to that? And if somebody wants to try coming off mute to reflect it back verbally, that's completely okay too. Your friends are really important to you. Your friends' opinions are important. Yeah, really highlighting. You're worried how others might judge you. Absolutely. These are great examples of reflections. And it can all serve to carry that conversation a little bit further around what does that mean for them moving forward and the decisions that they make. Yes, thank you, Nicole. Understand that you value your friends' concerns, or I skipped ahead, opinions of others, and that was Dolores's. And okay, and how about you? Yeah, good, Dolores. Okay, thank you, Katrina. And that concern that their relationships might be negatively impacted. And this is a very real concern for those of you all who worked with youth. Is social acceptance is huge, and that perception of acceptance can really influence behavior quite extensively. All right, we're going to skip this one because I think you all understand the reflections. Summaries are in some ways a glorified reflection, if you will. It's an opportunity to kind of reflect back the key components or key themes that were discussed. And honestly, in a brief intervention, you're not going to have too much time to do many summaries, maybe one or two. Where summaries can be specifically helpful is sort of at the conclusion of your discussion, but then also if you're starting to feel a little stuck or your client's heading in a direction that is taking a little bit off course. And again, because you have a briefer amount of time, you want to kind of bring it and redirect it back to the focus area that you're discussing. So it could be an opportunity to sort of pause, just understand, reflect back. Let me just pause for just a quick second, make sure I'm fully understanding, and then immediately kind of transition back into the conversation that in the direction that you're heading. Okay, great. So we're going to skip the group reflection practice because I want to make sure we have ample time for the brief intervention discussion and your questions. Now we're going to transition to the brief intervention. The brief intervention has a couple of main goals to help get you through this. So in your brief intervention, if you're able to build connection, that is going to be huge. We know that having a solid rapport is one of the strongest predictors or outcomes of any intervention. And so building connection is going to be critical to the success of the brief intervention, but really eliciting from the youth their perspectives and what's working for them, what's not working for them, their concerns, by using that open-ended questions and a reflective discussion. And then, of course, activating them onto a wellness path, engaging caregivers as needed. And one of the ways that we can do this is through something called the brief negotiated interview. There are multiple versions of brief interventions. We're going to talk about one. It's a semi-structured conversation, and it's been tested out in medical settings and healthcare settings to be an intervention that folks can effectively get through, that can have impact. In other words, it's been shown and tested to work in helping reduce substance risk. And it's something that can be fairly easily integrated into any conversation that you may be having with a youth. So we're going to talk about the steps, then we're going to walk through or watch another video of it, and then you're going to practice it. All right. So starting with the steps, the first one is engaging, right? This is where we're really building that rapport, using some open-ended questions to just get the conversation started. Most likely, from what I've heard from you all, many of you may have an ongoing relationship with the youth, and for some of you, you may not. You might be meeting them for the first time. And if you have an ongoing one, then you may already have this engagement piece built in. Naturally, you built that rapport, and this is just an opportunity as you're starting your conversation to continue to do that, just to check in, how things have been going for them. Otherwise, if it's someone who's brand new to you, it's an opportunity to just spend a little bit of time like you would any other client that you're working with, and just getting to know them a little bit better, asking them about themselves and things that are important to them, right? So that's engage. At some point, and relatively quickly in a brief intervention, you're going to switch over to focusing on the topic. The topic for the brief intervention in this case is going to be, assuming you've done screening before, it's going to be getting to a conversation around their substance risk. I want to highlight for you, if you have your PDF of the training manual on page 33, you'll see a page that has the brief negotiated interview on it. And that is something that you can use as a reference as we go through the training, as we go through these component parts, and then when you're practicing as well. So I just wanted to turn your attention to it. It does look like this. So it's got a green table, and this is on page 33 of the PDF that was dropped into the chat. So if you didn't get that PDF for some reason, just let us know and we can drop that back in. But otherwise, that might be a helpful guide just to have available in reference, because then you'll get used to using it and referencing it and then practicing it here in just a little bit. So when we get to focus, this is where we're wanting to bring the conversation back over to what you're talking about. So it might be, well, I really appreciate you taking the time to fill out, some of the questionnaires that we gave you when you first came in today. Wondering if now would be an okay time for us to talk through that. And then transitioning into a discussion around that, right? Most youth are going to say, yeah, that's fine. And it's highly unlikely that someone's going to be like, nope, I don't want to talk about that. But by giving permission or asking for permission, you're really helping them feel a greater sense of agency and autonomy, which is going to help them further engage in the conversation. And I'm seeing here, Katrina, if we could please drop the training manual again, please. So I'll ask Elaine if you wouldn't mind dropping that in the chat one more time for the group. Thank you, Katrina, for letting us know that you need that. Okay, so you've engaged, you're focusing, you're transitioning the topic now to the topic of substance use. And this is an opportunity to then really start to hone in around their experience of substance use. So even before you even get over to the screening results or however you want to talk about it, is just getting a better sense of what does the substance, what role does that substance play in their life, right? And so this is where with this third step, you're typically eliciting pros and cons. You want to understand, help me understand a little bit. I noticed that you mentioned that you've drunk alcohol about monthly, it seems, over the past year, anywhere from 2 to 4 beers each time you drink. Help me understand a little bit more about your drinking. What are the things that you like about it? And so this is where you're getting, what are the drivers for that behavior? Anytime you're wanting to change a behavior, right, we need to understand what is pulling somebody towards that behavior. What is it that they like about it? Because in the back of your mind, you're thinking about what are some of the alternative ways they might be able to achieve those things that they're getting out of that behavior. So what is it that they like about it? What's pulling them towards it? And then understanding that, and then also asking what are the things that they like less about it or that they don't like as much about it. I tend to avoid using words like pros and cons. We're using that here as a way of us talking, person to person who would be delivering this. But with youth, I think they tend to respond, and not just youth, adults too, better to language about things that they like or things that they don't like as much or like less of. And it's a little bit softer, and I think it helps people open up to more possibilities using that language. So eliciting pros and cons, and this is part of a decisional balance. So for those of you who have MI training, you'll notice that, this is very similar to what you're used to doing if you're used to doing decisional balances, except in a brief intervention, we typically only have time to focus on the pros and cons for the use behavior, not the non-use behavior. So here's an example of ambivalence, or just an example of the exploring pros and cons that you can look at more later. But to get back to it, After you've engaged, you focus the topic on the substance risk, you've elicited their pros and cons. This is an opportunity to sort of make connections for them and discuss any health impacts. So this is where you, as a individual delivering this intervention, has an opportunity to provide input or feedback. And this is really important to do in a way that is not generic, but in a way that is personalized to that youth, right? So maybe you learned earlier that this is a youth for whom, football is a particularly important role in their life right now. And as is doing well in school, as is, making their parents proud, or whatever the case may be. And whatever you learn about them, you can leverage that. So I'm curious, when it sounds like you really enjoy this part of drinking, you like this a little less. I'm curious how your drinking plays a role and how this all fits in with some of those things you mentioned that are really important to you, like your football, how your parents feel about you, or whatever the case may be. And help them start to think through how the things that are important to them that they value, align, or maybe don't align as well. There are times where you as providers will also have an opportunity to offer input and education, especially if you're correcting misconceptions that the youth is sharing about particular substance or substances. And the recommended way to do that is just to offer to, is it okay if I offer some additional information about your understanding of that? And if they say yes, then you offer the information. And it could be somewhat more around, I know a lot of people here like to add an information around, well, you may already, I'm sure you already know this, that the youth brain is still very rapidly developing. And one of the things we know is that it can really kind of throw that off and be harmful to your brain and your overall development, meaning how fast you think, how quick you are, how you're able to do things like on the field, how you're able to do things in the classroom, can really kind of slow those things down, if the brain continues to be exposed, to alcohol over time. And just curious how, you think about that. So you're always going to ask to give information, offer some information, and then get their reflection about the information that you shared. And there may be times where for those who are higher risk, you might need to give a stronger clinical advisement that, as a provider, I do have to say that I am concerned about this particular behavior. And this is kind of in this section that you would do this kind of information sharing. So what you're done at this point, if you really kind of helped them to think through a little bit and quickly about what they like, what they don't like, offered some input, tried to make some connections to things that are important to them, all to get them thinking a little bit about how they feel about substance use, right? So we've identified any potential ambivalence. We're using this section 4 of connecting and discussing health impacts and things that are important to them to try to, reduce some of that, build the discrepancy so that hopefully they're wanting to reduce that discrepancy. And the way we get a sense of whether or not they're interested in reducing that discrepancy by making some type of change is to go to that next step, which is the readiness ruler. A couple of you commented on liking hearing this in the video earlier. The readiness ruler is just asking them on a scale of 1 to 10 or 0 to 10, doesn't matter which way, how ready are you to make some type of change to your use? Readiness can be assessed this way. Importance in making a change can be assessed this way. Confidence in making a change. But typically in a brief intervention, we're often going to be focused on readiness because that's what we have time to focus on. And then you get a sense of what their number is. As long as they're not 0, you affirm where they are on that scale. So you're a 4. Okay, so you're 40% of the way there. What made you a 4 and not a lower number like a 2? Now, why do you think I might ask why not a lower number like a 2 as opposed to, okay, so you're a 4. Well, what would it take to get you up to a 7 or an 8? You can come off mute too, because it might be easier to answer that verbally. So why aren't you? Yeah, it can put them on the defensive. So we want them to be thinking about and in the mindset of why they want to make the change. So that's why you ask why not a lower number, even if it's lower on the scale of readiness, because they're going to give you the information about why they would consider making a change. And that is going to help them move forward and considering a change as opposed to saying something along the lines of, well, you should, implying that they should be higher. Okay, great. Because then they'll start talking about why they don't think it's a big deal and why they may not be ready to make a change. And that's not the mindset that we want folks to be in. So the rule of thumb, if you have it, is to go down like 2 points on the scale. All right. So if they give you a 7, you go down to a 5. If they give you a 9, you go down to a 7. If they give you a 3, you go down to a 1. So goodness, what do you do if they're at a 1? Or they're like, you know what? I'm not on a 1 at all. I'm kind of like at a 0. Any ideas? I'm sure we've all worked with folks who have been at that level of readiness for some type of a change. Yeah. So what would have to happen to get you to a 1? I would ask what brought them in. If they're there, clearly they're there for a reason, right? And so what was it that brought them in and got them even to the door? And those are absolutely, this is kind of the one time where it might make sense to ask a little bit about, well, based on what we've talked about, I'm curious what are your thoughts on what would need to change or how your life would need to look different before it felt like the right time to commit to making some type of a change, right? Some of the ways that you can do this, imagining extremes is a common way of doing this. So this can be helpful with youth who are not really interested in using, in making a change. And one of the ways of doing this is thinking about a worst case scenario or even the best case scenario. So I kind of alluded to the worst case scenario. So let's imagine nothing changed. How would things look different for you? How might life look for you in 5 years? How would you know it is time to make a change? How bad must things get? In other words, for you to consider making a change. But then also the best case scenario. So you're here, something brought you in. Let's imagine you did make a change. What might look different for you in, say, 6 months from now? How would things be different for you in positive ways? And is that something that you're wanting to pursue at this time that would be important for you to consider? In a brief intervention, again, this is not treatment. If you have somebody who's engaged in treatment, you have much more time to work on motivational enhancement. But in a brief intervention, the goal is to really try to see if we might be able to activate some readiness into a behavior change, but also recognizing that for some individuals, they're just going to need a higher dose, if you will, than a brief intervention. They might need multiple brief interventions. They might be a better fit for ongoing motivational enhancement in treatment. And so that is okay. And that is part of the process. And that would be part of what you're thinking might make the most sense for them in terms of their next steps. And then once you've gotten a sense of their readiness, then getting a sense from them, what are the things that make sense to them? Like what next steps make sense to them? They've identified some level of readiness. So based on what we've talked about today, what next steps make most sense to you in helping reducing your risk or potential problems from substance use? And let them come up with and identify some strategies or some ideas. SBIRT is not an abstinence model. It is not a model at all. It is just a framework. It is a framework that follows the plan of the youth and tries to get them to a healthier place guided by you. Of course, there may be times where you might want to, if you have youth that you're working with that are really struggling and they've tried cutting back or scaling back and it's not been helpful, or they're engaging in something that's particularly risky and unsafe, it may be worth exploring whether they would be open to a period of time of not engaging in that use. And the doctor did that for a little bit, right? It was like a period of time of not using 2 months to see if you could go that long. for not using. But again, this is something that is going to be identified by them and then thinking through the basics of planning, right? So you've done this, I'm sure, in your work before. What do they need to be successful? Have they tried something like this? Are there additional supports that they would find useful to help them achieve this goal? And working to help them get connected. This is also where you would offer referrals. So for those individuals, again, the majority of the youth who get screened in the general population are going to be at that brief intervention level, and this is all they're going to get. For those who are going to be at those higher levels of risk, though, and or let's say they weren't, but you learned something in the course of your conversation that made you think, this person would be a great candidate for some ongoing support. This is where you would offer those. And would it be okay if I offered some suggestions that might also be helpful to you? And then try to see if they'd be open to engaging in that treatment process if they're not already in that process. If they are, and this is part of an early part of engaging into treatment, then this is an opportunity to highlight how this would be a plan that they can engage in, and then as they get enrolled with their provider, the provider could continue to follow up with them on and so on and so forth. Okay, so these are all the key components of the brief negotiated interview. I know I went through them somewhat fast, but I want to pause and see what questions that you have, because we're going to watch a demonstration video of this, and then we're also going to have you all practice this here in a little bit. Okay, I'm not seeing any questions come in. I'm going to go ahead and start the video, the next demonstration video. This one's a little bit longer. It's about a little over 7 minutes. So we'll watch this, we'll talk about it, and then we're going to put you in breakout rooms to have an opportunity to practice. I will say, if you do have it, again, page 33 is a guide that you can use to follow along if that's helpful as you think through the steps in the process. So if that's helpful to you to have as a reference as this intervention is going through, I find that always helpful for me to reinforce sort of the steps and the stages. That could be something that you might want to do. All right, so let me get this new screen share going. All right, are we able to see the gentleman on the screen? Excellent.
Hi, Vanessa. I'm Carlos. I'm the social worker here at the hospital. How are you?
I'm good. How about you?
I'm doing great. Thank you. I appreciate making time to chat with me. I know that your doctor wanted us to go over some of your assessment results, and so we can come up with a plan as you leave the hospital. I know you're supposed to leave later today, but before we do that, I just want to take a couple minutes and get to know you a little bit better. And so tell me a little bit about yourself.
I live with my friends. I'm in my second year at community college, and I work at a Korean restaurant.
Right, you must stay pretty busy. Sounds like you got a lot going on, working, also going to school at the same time, and also, getting out on your own with your friends. So that sounds like a lot of different things happening for you, which is great. Very cool. Well, I want to spend a few minutes now to talk a little bit about the information you gave us. Specifically, I maybe thought we could start with your alcohol use. Would it be okay if we start there?
That's fine.
All right. So based on the information you gave us, Vanessa, it looks like you drink about 2 to 3 times a week, and that when you do drink, you have about 3 drinks each time, sometimes as many as 8, and that your favorite thing to drink is margaritas. Does that sound about right?
Yes.
All right. And so, I'm hoping you can maybe tell me a little bit about the things that you enjoy about your alcohol use.
I mean, it helped me unwind, helped me relax. It bonds me and my friends, and it's my favorite thing to do at a party.
So a few different things that it does for you. One of them, it seems like it makes you and your friends feel closer together when you're doing it together. Something to do at parties when you're hanging out. Right. What about some of the not so great things that happen when you drink?
I mean, me and my friends got drunk. Some pictures were taken. And before they got to the internet, we kind of controlled it and took the pictures down. Not to mention, I was scared being wheeled out on a stretcher.
So maybe making some decisions that you wouldn't typically make if you weren't drinking. And also it sounds like kind of this health scare has been kind of a big deal for you, maybe even also for your friends. Kind of scary to have to be wheeled out in a stretcher in front of them. Maybe even a little bit awkward or embarrassing, but sounds like something that you'd definitely like to avoid in the future. All right. Well, I'm wondering if it wouldn't be okay for me to talk to you a little bit about a few of the things that we know about alcohol use in young people. Would you be okay with that?
That's okay.
All right. So first of all, I think one of the things that we know about alcohol use in terms of young people your age, and I know you mentioned you were 19, and so there actually aren't any safe drinking limits for people who are your age. And so your safest bet would be to not drink alcohol at all. Having said that, it's going to be completely your choice and your idea what you do with your alcohol use. And so there's a couple other things that I'd like you to know. One of them is that when people start to drink in larger quantities and more often, they tend to have more negative consequences. And so some of the things that you mentioned, for example, the health issues that are coming up, maybe making decisions around social media and posting pictures that maybe you wouldn't normally do if you wouldn't be drinking. And so, some things to keep in mind. The other thing with regard to your diabetes is that the American Diabetes Association actually has a couple of recommendations for people who are drinking alcohol and have diabetes. One of them is that you continue to talk to your doctor openly about your drinking and your alcohol use, which is something you're already doing. So I definitely appreciate that. I know your doctor appreciates it a lot, and so keeping that conversation going. The second thing is that they recommend that people stick to the low-risk drinking limits. And so I'm not sure if you know what those are, but I'm going to explain those to you and just see what your thoughts are here. So for women, low-risk drinking limits are no more than 1 drink per day and no more than 7 drinks in a week. Also, not having any more than 3 drinks at any given time, at any one time, okay? So when looking at these numbers and also looking at what you told us earlier, it seems like you're drinking a little bit more than these limits. What are your thoughts about that?
Boring, but reasonable.
Okay, so maybe not the most exciting thing, but something that, may be okay depending on what your decisions are around taking care of your health. Okay. Keeping that in mind, Vanessa, I'm curious where you are in terms of making a change with regard to your alcohol use. And so what I'd like to do is take a look at this readiness ruler. What you'll see is it's a scale that goes from 1 to 10. In this case, 1 means that you're not at all ready to make any changes about your alcohol use. And 10 means that you're extremely ready to make some changes with regard to your alcohol use. So on this scale from 1 to 10, how ready would you say you are right now to make a change regarding your alcohol use?
A 5 or a 6.
All right, so right here in the middle, 5 or 6. Great. So Vanessa, tell me why you didn't pick something lower like a 2 or a 3.
Because I don't want to end up in a hospital again. Hospitals for sick people. And I guess I got to get smarter about my drinking.
Okay. Yeah. Seems like maybe you're not really feeling like this is a place where you belong, still really young, really independent, wanted to take care, really take charge of your health. And so very different from, the way that you see your life going. So, okay, that makes sense. In thinking about a change that you might be willing to make right now, what do you think is something that you'd be willing to do in terms of a change in your alcohol use?
Reducing my drinking for a while, just to see how it goes.
All right, so cutting back on your drinking. What does that mean? Would that mean going a couple weeks, maybe a month without drinking alcohol?
Maybe not drinking for the next 2 weeks. And then next time I take a drink, I'll think about these guidelines first.
All right, so a couple weeks without drinking any alcohol, and then if you do decide to go back to drinking, then thinking about these low-risk limits. All right, that sounds like a great plan. Do you mind if I make a suggestion of something else you might consider doing?
That's fine.
All right, so something else you might consider doing is talking to our diabetes educator. So we've got a diabetes educator here at the hospital, and they could help you make a plan related to your alcohol use and your diabetes, as well as other aspects of your diabetes so that you can really take charge of your health like you mentioned you wanted to do before.
That's fine. I'd rather make a plan just for me because I'm not about to go about these brochures. I'm not like everybody else.
Yeah, really making sure it's individual to your needs. That makes sense. I think that sometimes those brochures provide some good general information, but really making it specific to you sounds important. So great. Well, I know that the diabetes educator is somewhere around here, so how about we go find him right now and maybe you can have that conversation. How does that sound?
Okay.
All right, let's do it. I appreciate you chatting with me, and let's go find him.
All right, so I look forward to hearing your feedback on that. What are the things that with that intervention that you felt worked well? You can drop it in the chat. You could also come off mute. Yeah, Carlos really, he had a lot of good affirmations in that dialogue. Dahlia?
Can you hear me?
Yes.
Yeah, I just wanted to say I really liked his tone. I liked that every time he had a question, he would ask, like, is it okay if I give you some suggestions? What are your thoughts about this? So not judgmental, but just having like a really genuine conversation with the youth.
Yeah, absolutely. And it looks like a number of the comments coming in the chat agree with that statement exactly as well, around him just being very engaging, non-judgmental, easy to listen to, and his good tone, reflective listening, not threatening, found her own motivation, met her where she was. He was very affirmative, absolutely. And you noticed in doing that, he maintained that stance. A lot of y'all are commenting on his overall approach to how he was, his SBIRTness, if you will, in that conversation. And yet he still made it through the different steps of the brief intervention. And I'm curious if you all had any reactions to specific parts of the brief intervention. You know, he was using similar sort of as the brief negotiated interview, as we talked about just moments ago, and was able to apply it while maintaining that stance and that approach throughout. So any thoughts, reactions to that? All right. Were there any things that you didn't like as well in that delivery of the brief intervention? Yes, Marilyn offered that she loved when he asked if she had a plan. Or, oh, if I may, yes, if he could add to the plan. Would it be okay if I offered something to add to the plan? Yes. Everything was very individualized. Was there anything that you didn't like or that you would have done differently? It does seem so brief. Hence the name. Yeah, a little scripted, right? Yeah, it's hard to find these in natural environments and have an opportunity to tape them. So there is a little bit of that for sure. But does it feel at all realistic? Like this could be a potential conversation that would happen, you know, and that's something to be thinking about. Not behind the desk. Yeah, Patrick, you know, that I agree with that too. That's my approach. I would be more alongside in these conversations in a different sort of room format. May have explored what was boring about the drinking guidelines. That's a good follow-up to do. Yeah, it could be that bringing up the diabetes management as well. They do go, I mean, this was a hospital context, so I can see why they did that. You know, the referral came specifically from the diabetes around the concerns of how the alcohol impacts the diabetes care, but it could be overwhelming for them to leave with both goals of diabetes management and a substance use. So it could be that additional supports might be beneficial in that case. I think one thing I wouldn't have done, I think with a youth, is probably spend so much time on the low risk guidelines because they don't technically apply under the age of 21 anyway. All right. So now that we've had a chance to do that, what we're going to do is I wanted to first ask you all whether or not this feels doable and achievable within your respective roles. And start thinking about what concerns you may have, because before the end of the training, I'm going to have you come back around to that so that we can discuss it. And this is what I mean. I've already seen Mary Lynn brought this up, but this often comes up, is this is very brief. But remember, this is designed to be a brief and early intervention, of which multiple can be had. It is not designed to be treatment. And so whenever we are used to a treatment, we're coming from when you train providers who have 15 minutes per patient all day throughout the day to do brief interventions, and they're like, what? I have to do this, and I can't spend 5 minutes. I have 2, right? And then on the other side, when you have people who are used to having 45, 50 minutes with folks, and you're saying doing a brief intervention, it's a different type of approach that we may or may not be used to or trained to do. And so one of the things is recognizing that there might be opportunities. You have to think about how can I move this along in a brief way? Because I've just done this intake and I've identified this risk, and it's going to be several weeks before this client gets to their clinician. And I want them to get thinking about this process, but I really only have 7, 8, 10 minutes left to talk about this with the youth. And how am I going to make the most use of that time until I can get this person back for a therapy appointment? And, this is how that semi-structured approach can be helpful in that way. Or you're following up with all the 8th graders after you've done, these screenings within your school, and you're slowly going through them, and you may not have time, but you can identify for those who might need to come back for more, or to be referred to somebody else for ongoing support. You can do that. But for many of the youth, again, who this is trying to get at that earlier stage of use, this can be an impactful first step. And you can do it multiple times, or it could be a one-time sort of experience. And that's all dependent on the nature of the presentation. Okay. All right. We're going to talk some specifics at the very end. But what we're going to have you do first, and I'll go ahead and get my screen share back on. Good. Here we go. Okay. It doesn't really matter which slide. You're seeing the presenter slide now? Or are you seeing the regular slide?
You see the presenter slide.
It doesn't really matter if I can just make this bigger. Here, let me just stop it and start it again. For some reason, depending upon if my Zoom is up or not on which screen, it changes it up on me. Here we go. So we're going to have you all go into breakout rooms and have an opportunity to practice this. So if you have your guide, your booklets, what you can do is turn to, let me get the specific page here. Oh, you know what? I extracted it out. I was going to have you all just come up with them on your own. Okay, so what I'm going to have you all do is practice. And in the first group, what we're going to do is we're just going to have you all identify one person who is going to be the youth and one person who is going to be the provider clinician. And it doesn't matter who goes first, because you guys are going to rotate and you'll flip roles the second time around. In doing this, when you're playing the youth, we're going to start with thinking about someone who's low risk. What's that mean? That means that they're using some substances with some frequency, but they're not having too many problems yet. They're having enough that it's, enough to get a brief intervention, but we're not talking at the level of substance use disorder. All right. And this is for the purposes of practicing, but also because this is really the intended population for whom SBIRT is designed. I'm seeing a couple people saying that the guide is not opening for them. It may depend on the type of Zoom that you have. It should be a matter of clicking to download. And then I don't know if Elaine is able to put any additional guidance in the chat on how to do that. That would be great.
So for those people who are having trouble, I've been emailing them the document. So if you just drop your email in the chat, I'll email. You'll get it this afternoon after the session, but if you want to look at it right now, just put your email in and I'll send it.
Yeah.
If
Okay.
you are driving, do not download anything. What are you thinking?
Yeah, no, that makes great sense. So what we'll do is, for those who you don't really need the binder at this point, if you have what I have on the screen, we'll keep this on the screen. I don't know, is it possible to, Elaine, to broadcast this in the breakout rooms?
Okay, so my license doesn't do that, but really you can get around that by just taking a screenshot of it before you go into the breakout rooms. Use your phone or just your snip tool and take a image of it, and then before you go into your breakout.
Okay, sounds good. So thank you, Elaine, for that additional guidance. So what we'll have you do is you'll go into your breakout and just work through these different steps. As you're playing the role of the youth, again, because this is just an opportunity for the person that you're paired up with to practice putting this together, we ask that you take consideration in how you portray that youth. So you may not want to be, I know it can be really fun to play those really stubborn or sometimes difficult clients who give you very little and put up a bunch of walls. But for the purposes of role playing, we just ask, the goal is to really not learn how to deal with a more challenging clinical situation, but to how to get through the steps. So just please take that into consideration when you are playing the youth role. And I'm sure your provider will be very appreciative of the opportunity to just kind of get through the steps. So what questions do folks have before we go in and do this? And you don't have to do the screening. Instead of going, we're not going to do the screening ahead of time. You're going to assume that you have some information about that youth substance use, and the youth can quickly share what substance or substances they use and with what general frequency. And then you all can get started from there. So for instance, I see Alicia here. If I were paired up with Alicia, I would say, Alicia, I'm the youth in this case. I, use nicotine pretty regularly, throughout the week. And so far, my parents have complained about it, but that's really the only problem that I've had with it. And I would just leave it at that. And then Alicia would have that information and she'd start with engaging. All right, so Patty, tell me a little bit about yourself, assuming that we're just now getting to know each other. All right. And then that would start the engagement process. And then she would go through the remaining steps in the brief negotiated interview. So what questions do folks have before we get started? So you're going to be put into breakout rooms. If you're in a situation where you can only participate or you cannot unmute or whatever the case may be, don't join the breakout room and we'll get people reassigned if we needed to. Jackie, it's page 33 of the manual if you have that available to you.
Recorded.
All right, the rooms are closed. Everyone's back.
Excellent. Welcome back, folks. So we're going to spend the remaining time. We've got about, 17 minutes until the training is over. We're going to use every last moment together. We want to spend a few minutes just getting a sense of how that experience was for you. This is definitely work better if you come off of mute. So feel free to raise the hand to be called off mute or to come off mute, however you want. I don't think we're going to have too many people talking over one another. But let's just talk for a few moments about what worked, what went well, and what was more challenging. And think about it both from the perspective of the client as well as the perspective of the provider.
I'll say for me, it was really easy to be the youth and do the scenario. When it was my turn to be the counselor, I think I just need a lot more practice with some of this stuff because it was like I could feel it naturally coming out with not being judgmental and things like that. But it was the the scaling process and taking what the mock client was saying and trying to implement some of the stuff that like the process that I was struggling with. But overall, I mean, like, I think it went really well, and yeah, just need a little bit more practice.
Sure. Shelby, I appreciate your sharing that experience. We often hear that and find that putting it together into its component parts the first few times can feel a little less smooth than the way you might be used to delivering, the work that you're doing with clients that you've started to grow accustomed to how to do already. And that each part itself may not be that difficult, but just remembering sort of the synthesis and the ordering and having it flow. And you're absolutely right. That is something that just comes with time for sure and ongoing practice. How about for others?
I thought the guide was very helpful with guiding me through this process, being that it was my first time. But I agree that the skills are there that we're using to to engage in the empathy, but just making sure that we're polished with the actual providing feedback and the supports and those things. And like you say, it will come with time. But overall, I think the guide was very helpful.
Good. I'm glad you found it helpful. Thank you for sharing that. Are there areas that maybe you feel you would like to use some of this time to get some additional support around or clarified questions answered that you may have about putting this all together?
Okay, I would say trying to project my values on the student. I would say I'm listening, but then I'm saying, well, and I realized I was projecting my values, my thought processes onto them, and hopefully that they would understand and agree with me. So that would be something I would need to work on. But I know what I was saying was right, and it would have been a positive outcome. But for them to do that themselves.
That's right. It's that ever-growing battle that requires patience and restraint at some point to say, to allow them and to guide them to those conclusions and to some of those answers. And, also when it is appropriate to share information, and it's how you share the information, not whether or if you do or don't. And I appreciate you bringing that up, because especially if it's a slightly different way of talking with youth, and because maybe your role has you used to engaging with youth in different ways, it is something that can feel foreign. But I love how you're having an awareness of that right off the bat as you're going through and putting it into action. And I think that'll be really helpful. It'll continue to remind you with each iteration or each conversation about how you might want to consider trying it this newer way, or different way, I should say. All right. Were there any other folks that wanted to chime in before we head on to a couple of final thoughts and some ideas before we wrap up the training? All right, so I'm going to go ahead and let's get this last little bit of slides covered together. And you'll notice that I'm starting to lose my voice. And luckily that that waited for the last little bit of the training. So we should be good from now. But if I sound a little raspy, I don't know, it just suddenly started. All right. So post the brief negotiated interview, we started to talk a little bit about this. What do you discuss with parents? And again, I think this is where the answer to this question will in somewhat be informed by your setting, the way in which you're doing screening. So for instance, in schools, a lot of places that will implement Youth SBIRT will implement a notification letter to all families that of the youth who are going to be screened that year at the very beginning of the year. And it's almost like an opt-out, like it is a lot of things. This is happening. We're asking questions of a number of risk factors related to health and wellness, including maybe it's anxiety, maybe it's depression, maybe it's substance risk, whatever it is that you're screening or identifying. And that including in there specific information around they can opt out if they want, but then also what can they expect? Like that, what is confidential? At what point would they caregivers be expected to hear? And so being able to think through as an institution, as a district, what is going to be the approach for that, and how you can inform both the youth and or the caregivers around expectations around confidentiality and when that would, of course, need to be broken to ensure safety and protect the youth. In other settings, where a caregiver may be accompanying a youth to their appointment or not, and otherwise be involved in the process for services, this is really going to be negotiated based on whatever is the typical model. So you'll get a sense of, is this youth able to make this change on their own? And is the risk at a level such that I wouldn't normally need to break confidentiality? But recognizing that for youth, some of the most effective outcomes are when they have the support of the family. And so when the family is a source of support. And so being able to negotiate with the youth what they think, what would be helpful for them in terms of others being involved in that process, other trusted adults or individuals being involved in that process with them and then engaging those. But always remembering that, to follow the guidelines and policies of your respective practices around when disclosure needs to happen. And there's some clear, like, no, disclosure doesn't need to happen, and some clear yeses, disclosure does need to happen. And then there's that gray area. So always seek consultation with your peers and your leadership around that. Very briefly want to talk about active and collaborative referral to treatment. And those words are highlighted here because we know that a lot of referrals end up not actually happening when it's just a matter of sharing information, name, number with another individual. And so what SBIRT recognizes is that if we're able to use that brief intervention, and in that moment, if an individual is willing and actively interested in engaging in additional support services and treatment services, we want to capitalize on that motivation. And so that can look a number of different ways. That can look like doing ongoing follow-up and brief intervention checkpoints after that that particular day or session concludes, so that you can check in with them and keep them engaged with some type of support mechanism. And each time just checking in about how their plan is going, how their use may have changed, identifying additional ideas or strategies to help them be successful in making the change, and so on. And the referral process, just a couple of things. Ideally, warm handoffs are the best in terms of, showing successful connection from provider to provider. Fewer folks sort of drop in the referral process when there is a warm handoff. But in the absence of being able to physically do that, just being able to explain the process, what can they expect next in terms of their care? Who will they be connecting with next, and when, and what will that look like? Being able to talk about different treatment options that are available, and so on. I'm sure you all do this often, but want to make sure that you all are just kind of aware of some of these key points that the SBIRT framework really holds as foundational to an effective referral process. Follow-up is in fact shown to be effective at helping people. So there's actually controlled trials that show that having a brief phone call within a few days or weeks of a brief intervention dramatically, reduced risk, basically supported the treatment plans, both in terms of reduction of alcohol intake, reduction of binge drinking, negative consequences, and injury. This specific study was looking at SBIRT for alcohol, which is why the outcomes were all alcohol-based. And a lot of places will just consider, part of our standard of care, our process here is that we do have follow-ups. And is it okay to go ahead and continue to follow up with you and check back in about how things are going? If you're working in a small community, oftentimes, or you have your youth are interfacing with a couple of other agencies in high frequency, it can be helpful to kind of have a streamlined and bi-directional communication channel in place with those agencies and other treatment settings, so that, you know, information can be shared with the youth and or caregivers' permission, of course, signing the appropriate forms. And you can always be informed about, did they make it to point A or point B, and so on. Charting and coding, for those of you all who are going to be delivering brief interventions. Brief interventions are, in fact, screening plus brief intervention have a code, a billing code, and it's for screening and brief intervention. So both have to be done. There are screening only billing codes as well that are different. And if you are going to be billing for screening and brief intervention, some of the expected key elements that you would chart to include this information. So basically you screened, what screening tool did you use? What was the general risk range? What was the intervention, the disposition plan, and so on. I believe we talked a little bit about parents earlier. I think we touched up on this, but in general, when a referral is needed, even though in Virginia, youth can initiate treatment services as young as 14, the likelihood of them successfully doing so and having the financial support to do so is not as realistic at that age as it is for an older adolescent or a working adolescent or even an adult, obviously. So more often than not, engagement is going to necessitate some type of caregiver involvement. And we also know that that leads to the best outcomes. One of the things about how you inform a caregiver who may not be aware of substance risk in their youth is to really highlight the positives and the strengths that, you know, we talked about a number of areas today, a number of topics with your child, and you know, they expressed to us and shared with us. This is, of course, after you've negotiated with the youth that you're going to have this conversation with the parent, that they have been engaging in some substance use. And I just want to highlight and say that we're really proud to see how they felt comfortable in opening and sharing that. And importantly, recognizing that it's something that they do want to change and have already started a process and thinking through how they could do that. And also thinking through how now you might be able to help support them in that process. And here are some ideas, you know, and things that we want to explore with you about possibilities for helping support them as they really want to aspire towards their well-being, right? So what you're really highlighting is you're affirming the youth strengths, motivation, awareness, and realization that they're looking to make healthier choices and options, and that they could really benefit from some additional support from them in doing that. All right, so I already talked about that. I just basically highlighted those last few slides in that one conversation with you all. And just in last few moments, I want you to be thinking about how are you going to fit SBIRT into your role. So whether your role is intaking and assessment, diagnosing, planning, implementing, evaluating, wherever it is, you know, these are all typical roles that we find folks, providers within the types of settings that you're working in may fill. And there's a role within SBIRT within all of these. So I'm going to take the slides off. We have just a couple of minutes. I started the training by saying, I really hope that by the end of this, you all have a clear sense of not only comfort with an awareness of some of the screening tools and a comfort with delivering the brief intervention, but an idea of how you might be able to embed this into the work that you're already doing. And if there's question about how to do that, now's a great time thinking about, well, I'm not really sure with my role for this type of setting, what might make sense. So feel free, let's bring out those questions if you have them, and let's get those answered for you before we wrap today. And any other questions that folks have. And if you didn't see it, Denise, sorry, I don't know why I keep saying Denise, Elaine, did drop into the chat a quick evaluation of today's session. So complete that, please. We're really excited to hear about how this went for you. We always want to, you know, make sure we're meeting the audience. And because this training can be delivered to a vast number of different audiences and different types of roles, want to make sure that we're able to meet that need. But also, if anyone's interested in a participation or CE continuing education rather certificate, it is required to have the evaluation completed in order to issue those. Final questions from folks? If you have no questions, feel free to wrap up then, complete your evaluations, and we'll be done for today. If you do have them and you want to hang on, I'll sit on for a couple moments so that we can go ahead and get those answered for you.
Yeah, send it to her.
And thank you all for joining today. Wish you the best of luck implementing SBIRT.